Today's episode of the StallSide podcast was brought to you by Rood and Riddle Veterinary Pharmacy.
Hey, bud, how you doing?
I'm great. How about you? It's a little gloomy today. Ready for summer?
Yeah, it's fair enough. Great guest on the show today.
Absolutely. Somebody we're thrilled to have back with us. Dr. Erica Dobbs has joined our back here with our imaging team. She went away, got some training, and now she's back.
Yeah, she was a great intern, and she went and got some practical experience. I mean, she's really grounded in, she's done some lameness stuff, and she's really grounded in the athletic performance horse. And she has a very unique qualification. There's not too many people that have actually got their radiology boards with an equine diagnostic imaging focus.
Yeah, and she's very quiet, but she observes and she soaks stuff in. Very curious person. She can be a real asset here.
Yeah, absolutely. We're absolutely looking forward to what she's going to do as she develops her career through the years. So on StallSide this week, Dr. Erica Dobbs is going to be talking about advanced imaging, chiefly the PET scan. Dr. Dobbs, welcome to StallSide.
Thank you so much for having
Erica, thanks for joining us. This is great.
Yeah, really good. Erica, tell us a bit about yourself.
Well, I grew up just outside of Minneapolis, Minnesota, and I started riding when I was 4 years old, and I think immediately knew I wanted to be an equine veterinarian. My family was really supportive. They bought me my first pony when I was 8, and since then I haven't done anything else really. So I went to undergrad at the University of Minnesota. I studied genetics, and then I immediately went to vet school after that, also at the University of Minnesota, where I met Dr. Troy Trumbull, who became my research mentor there, and he really encouraged me to come here to Rood and Riddle as an extern. So I ended up coming here as an intern, and I loved it, and I kind of I would say I followed Dr. Garrett around a lot because I was really interested in imaging and lameness primarily. And then so after my internship here, I actually ended up going back to University of Minnesota and doing more gait analysis research with Dr. Trumbull, which I had started as a vet student, and just continued on with that. And I think also during that time, the ambulatory service at University of Minnesota was looking for more help specifically for emergencies. So during that time, I also did some emergency on the ambulatory side, which is a different experience for sure.
That's available here if you want to do some emergency ambulatory stuff. That's great.
Yeah. And with the other 28 hours of her day, she does. Yeah,
exactly. Wow. So what was your alternative? You didn't get into vet school with the genetics. I'm interested in that.
Yeah.
Yeah. Well, when I was in undergrad, my dad has type 1 diabetes, so I got really into that. Even in high school, I was interested in diabetes research because he supported a lot of organizations that did research. And so I got into a stem cell lab at the University of Minnesota where I worked for 4 years. And it was kind of in that experience that I got really interested in genetics and developmental biology. And so I think maybe perhaps if I hadn't gotten into vet school, I was very interested in endocrinology, and maybe it would have been either in human medical research or maybe medical school, but that was kind of my other great passion was diabetes research.
I was just curious because genetics was second for me too.
Oh, really?
That would have been great. That'd have been fun.
Yeah.
Okay. Well, I think I'm in the presence of two very smart people.
I became an ambulatory veterinarian.
Yeah. Well, that means you are smart. No, that's great. So you went and you ended up doing radiology residency. Tell us about that.
Yeah. So I think it was during all this time where I was doing research, I was doing ambulatory. The thing that I loved the most was doing imaging, and sometimes even the ambulatory service would send me out on imaging missions, where I just needed to go do that. And so that's kind of like when I knew that I wanted to do imaging. And so I did actually come back here after my internship and spend a couple weeks with Dr. Garrett. And I told her, I was like, I really want to do a radiology residency. And at that time, the only option was the traditional ACVR track, which is primarily small animal. And so I was like, I'll probably have to do a small animal internship to try to get this residency. So that's kind of like what I told her. And then probably about 6 months later, UC Davis started like a very quiet advertisement for an equine diagnostic imaging specific residency. And so I kind of like stalked their website because they also have an ultrasound fellowship for large animals. So I was like, well, maybe I'll do that. And so I applied for that. I didn't end up getting it there. But then I think like a month or two after I found out that I didn't get that residency, Dr. Garrett emailed me about an opportunity at the University of Pennsylvania's new Bolton Center. And so that is where I ended up going, and like very fortunate to go there and spend 3 years.
Yeah, well,
amazing.
Really cool area.
Yeah, UPenn's a great place, and they have a fantastic caseload, and they're really talented. So, I mean, you've had great foundational experience with all the like practical work you've done before you've done the imaging. So, you're a very exciting addition to our team. What would you like to talk about today?
I would like to talk about positron emission tomography. Is something that I got to do a lot in my residency since we have a PET scanner at New Bolton and also here. And so it's been like a very exciting area of growth in the past few years, I think.
Okay, so tell us what the applications for PET are going to be. How is that different than other imaging?
It's different from other imaging in that it's a functional modality, and so we get information about from 2 different radio tracers that we can use, either bone remodeling or for soft tissue injuries, looking at increased glucose metabolism.
I think that's the thing with bone too. I think people think bone is just static, but bone's actually really dynamic. Like it's constantly realigning itself to the forces. Like bone's actually really clever.
Yeah, no, and it is, like you said, it's changing all the time. And that's why the PET scan works, is because you're getting all these different markers and things in there that we can pick up, which I'm sure you're going to describe for our listeners.
Yeah, so what would be the indications, say, to use the PET scan? You're not going to run to that necessarily straight up, but if you did, what would be the indications for you to say, hey, let's do the PET scan on this one?
Yeah, there are a couple of different options. The first would be the horse has either gotten a different cross-sectional modality, so either CT or MRI first, and we find either multiple problems or maybe like a questionable finding, and we want to investigate the activity of one of those lesions and see like either what is the primary lesion, like are they all active, so that would be one.
Gotcha. So just because you've got 2 lesions doesn't mean that they're causing a problem, right? You're going to see the one that's inflamed and remodeling on the PET scan.
Yep.
Okay.
Great. So what's the process of doing the PET scan? You mentioned there's a couple of different radionucleotides. Say I rolled my horse up to you and you said, hey, let's do a PET scan on this horse. What would be the process? What would I have to present? What would I have to do to present the horse to you correctly? And what would the process be as the horse went through the hospital? Yeah,
so it's becoming increasingly common to do a dual tracer, so both the soft tissue and bone tracer, just to like rule out if there would be either bone or soft tissue injuries. But the first most important thing is to have the lameness localized to a specific area. So doing diagnostic analgesia first, because the way that the scanner is designed, it's not like the bone scan for general scintigraphy where you can do the whole horse. You can really do only a localized area in the distal limb, so either carpus or tarsus and below. And so having like a specific area of focus is really critical.
Yeah, so in a nutshell, this isn't a fishing expedition, because sometimes scintigraphy is a fishing expedition, right? You do the other things you can't see, but PET scan, you must know the area and you must be very focal in the area because of the fact that this is not a very big instrument. Yeah. Okay. Great. So, do you have any images you could actually show us? And for those that are not watching, could you describe?
Yes. So I have a couple that I brought along with me. The first is just the raw data that we get back from the PET scanner itself. The way that it's designed, its advantage is that it's three-dimensional, and so we're able to do multiplanar reconstructions, which is you're looking at a sagittal plane and then the transverse plane. And this specific horse had a third carpal bone injury, so had increased radiopharmaceutical avidity in that. And then I also have this is another multiplanar. This is a little bit more difficult if you don't look at these all the time. This is a fetlock. So we have like the third metacarpal bone, P1, if you can see my cursor there. And this is a very classic lesion of the palmar distal condyle lesions, also colloquially known as the pod lesions. And so like bringing this across, like in the fetlock, it's a very classic location. And one of the good things that we can do when we have also a CT or MRI is we can co-register the images. And so this is a co-registration of like a similar, it's not the same horse exactly, but it's a similar situation where it's a palmar distal condyles. So that can really help us with.
So do you remember the old aspirin commercials where the guy would go, ouch, and grab his shoulder and then there's this bright red?
Oh, yeah.
That's kind of what those look like.
Yeah.
You know, it's kind of when you lay them over top of each other, that bright red light shows up. This is where it hurts.
Yeah, well, that's just so old that I only had a black and white television, so
Yeah.
I couldn't see the color. But yeah, that's the thing for the people that couldn't see the images is that the red. I mean, and it really stands out from the tissue around there. There's a little bit of a smattering of red, but those images you're showing, I mean, that is really lighting up. So this is a really good one for anybody that's listening to actually come and have a look at the YouTube.
Are they all that positive? I mean, or are you getting more subtle changes in that? Did you show us one that was extreme there? Or is that fairly typical?
This one, so this horse actually was a sound horse, came in with bilateral lesions looking like this. But I guess this one is pretty dramatic, but especially dramatic for a sound horse.
Yeah, so that's actually a really interesting point because you talked about localizing the lesion before you look. Why did you look in this area if the horse was sound?
So this specific one I took from a study that's ongoing with Penn and UC Davis, where they're doing this multi-center, screening of racehorses with PET and CT. So they have like a specific requirement that they had to be like finishing in the top 3 of their last race, just to see like what's happening in these like well-performing horses. So it's a little bit scary to think that this was happening in a horse that was like proclaimed to be doing well.
But that just indicates remodeling. It doesn't indicate necessarily that there's a painful lesion there, right?
Yes. Well, the problem is that we have on the CT, he does have morphological change to the subchondral bone. So this horse actually ended up getting 90 days of rest because of the scan.
Oh, okay. So this is great. So you can look at this and say, hold a second, this horse is barreling towards having a big problem, and you're actually able to divert this horse and say, no, we need to back off on this horse, give it some rest to give nature to take care of it.
That's kind of what we're hoping that the PET scan does for us. It shows us these horses that are headed towards problems before the lameness.
Before they have them, because that's huge, because nobody wants to see a horse actually have, like, pull up lame after a major race. I mean, this tool, looks really useful for actually finding those horses. So the process, you mentioned there's 2 radiopharmaceuticals that you can use. And so if I brought you my horse again and you decide it needs this, so how about is that staged? Do they get them at the same time? What's the time interval between putting the radiopharmaceutical in, doing the imaging? How critical is that? Is there any special management with the horse like there is with scintigraphy, because you've got to keep them warm?
Yes. We also keep them in the heated stalls, so they're nice and toasty. The other important considerations are that we're wrapping the legs before the scan, the night before the scan. And then before they get injected with the radio tracer, they get a 10 to 15 minute brisk walk just to make sure the blood flow is adequate for delivering the radio tracer. And then more recently, we have decided to divide the radio tracers into 2 different days. So we'll do FDG one day, and then the sodium fluoride, or the NAF, the second day. And the reason behind that that we found here was when we were doing them on the same day, we were doing FDG in the morning and then the sodium fluoride in the afternoon. And when we were doing the sodium fluoride in the afternoon, we just weren't getting as good of images and uptake. And so we decided to make that change. So unfortunately, like, the horse has to stay here a little bit longer. And luckily the half-life of the radioisotope is shorter, but they still have to stay at least 6 hours after the scan.
Okay, so the sodium fluoride is the one you're doing for the bone, correct?
So can you describe how that works just a little bit? Maybe break that down to my level just a little bit.
So for the sodium fluoride, so that will attach to sites of osteoblastic activity. And so that will show, like, areas of active remodeling and, did that answer?
Yeah. So there's a couple different cell types that break down and build bone, right? Yeah. So when there's remodeling, these osteoblasts that build bone, right? So this molecule attaches to those cells and it goes to these areas that are building bone, and then the PET scanner can see those.
Yes.
Okay.
And the scanner design is such that, I don't want to launch into a physics situation, but it's like how the radio tracer emits positrons as it decays, that they are emitted 180 degrees from each other, and basically they use all those events to find the location of the spot of the uptake, if that makes sense.
Yeah,
yep, it does.
Pretty high-tech stuff. So how does it work in the soft tissue? So if the sodium fluoride gets onto the osteoblast and goes to where the bone's turning over, how does the soft tissue phase work?
Okay, so FDG stands for fluorodeoxyglucose. So it's a glucose analog.
Okay.
So it's transported into the cells that have high glucose uptake, but because of the fluoride ion that's on it, it can't go down the normal pathway of glucose metabolism, so it just gets trapped in the cells. And so then we can find those areas.
Okay, so the cells that were more metabolically active, like muscle cells, as opposed to like connective tissue.
Yeah, and it could be, because it was originally designed to look at metastatic neoplasia in humans. So you could find like neoplasia, you can find infection and inflammation. So anything that's like increased activity.
Yeah, okay, so one's for bone activity, the other one's for whichever tissue cell happens to be busy trying to use glucose, but it can't use this, and you can find it. Wow, that's pretty impressive stuff.
No, it's just when technology changes and you see how things work, you go, yeah, some really smart people figured that out.
Yeah, well, I started off doing radiographs in a dip tank. It wasn't that long ago.
No, it wasn't that long ago.
It wasn't that long ago.
You come back and you'd process those in the processor, it'd eat your films, and you'd have to go back out.
Oh, your chemicals are all wonky like this, and nothing would develop, and basically my images were no good anyway. Then you have to go back and take some more. I mean, this stuff is pretty impressive. So is there any limitations? You mentioned you do one day and one the other. Is there any limitations to like applying this technique to multiple areas of the horse? Like say you had a horse that problem one leg, problem the other, you wanted to PET scan both. Could you put the pharmaceutical in, do the same phase on two different limbs on the same day? Or do you say, okay, it doesn't last long enough for a vet to do that? What's sort of the time span that you can actually image the area that's got the radiopharmaceutical in it? Is it like hours? Is it minutes?
Yeah, we've got a pretty short time frame. So the half-life is 110 minutes, and we have to wait 30 to 45 minutes to start scanning the horse. So we have kind of like maybe half an hour, 45-minute window. So the most we've been able to do, I think, is 6 sites, but it was like in the same leg, and it was like it was kind of like pushing the boundaries a little bit.
So and how long does it take you? So say you want to do both front fetlocks. How long would that take you from the time the horse walks in to the time the horse walks out?
If the horse is behaving well, we'll walk in, sedate, and then the scanner gets moved in. The scan is like 5 to 8 minutes. So really, like if you only had to do 2 sites, the 2 fetlocks, it'd probably be like 20 minutes if the horse is being really good and because we have to do scouts as well, just to make sure that we have the right area, and then the scan.
So, because I think that's one of the things that people wonder about. Why aren't we using this for a screening technique for every horse before they race? But there's some limitations, right? Because the chemicals you're putting in them are not completely safe, and there's a time limitation factor there too. It sounds like.
Yeah. And like the technicians here are amazing at being so efficient and moving the scanner around to the other side of the horse and getting everything.
Yeah.
So.
What's the time of acquisition of the images? Because with some of the standing procedures like MRI and that, motion correction is a major issue. So is acquiring the image here pretty quick and motion's not an issue, or is there software to compensate?
Yeah, the scan itself, they're usually 5 to 8 minutes, but there is very robust motion correction that they've worked on, I think, extensively with the company, and it's very good. So motion is still an issue.
Yeah, but I'm impressed by those images. They're crisp. They're not fuzzy.
Very nice.
They're not like those radiographs you used to put in the dip tanks. They were fuzzy, but we thought we had something. I mean, that's fascinating stuff. So where do you see this technique going? Like you talked about that study where you're finding these horses that didn't expect to sort of see any changes. Where do you see this going? I mean, Bart mentioned you can't scan every racehorse. So how are we going to target this to do the best for the horse and best for the people associated with the horse?
Yeah, I guess maybe this is like a little off topic, but I think like identifying the horses with some kind of like objective gait analysis that like need to be maybe screened with PET scan would be like one way that I see this going. And I think there are like a lot of options for technologies that are like coming up for gait analysis.
So pairing this with some of the things we've talked about before,
Yeah. And so the order that you do things in, horse comes in, like there's a gait issue, you identify the region where it's laying, regional analgesia, right? How long after doing the nerve blocks, the regional analgesia, would you be able to do this? Because there's a soft tissue thing. So what is the gap there, right?
That's a great point. We like unofficially have been waiting like a week to make sure, because we did have one that, like a referred case that we didn't know was blocked like the day prior, and I was like, interesting that I got a lateral PD yesterday and there's this little blob of uptake right there in the fastern. So
but that's really important for client expectation management, because they think they're going to roll their horse in, do the diagnostic nerve blocks, and then just blow straight to the PET scan. Can't be done. So like a week or 10 days. Okay, that's very interesting information to know, that it's that good at picking things up, but also that the tissue is still turning over after just that, what you consider to be a routine nerve block, that long after the procedure is actually pretty sobering. Yeah. So what order would you do this in? Again, you have the horse, you do the block. Would you do radiographs first? Would you do CT first? Whereabouts would PET fit in your order of diagnostic imaging?
Yeah, I think still doing the kind of frontline, so to speak, diagnostics like radiograph, ultrasound, making sure that there isn't something that you would like easily pick out with those, but often they're being kind of done in the field. And then I think either CT or MRI, depending on what you're most suspicious of, as far as bone versus soft tissue, and then doing the PET scan after that. But there has been some suggestion of using PET scan first and doing a dual tracer and then deciding like, do I want a CT or an MRI?
Okay. Oh, okay. So bone versus soft tissue, and this can actually sort the. Oh, wow. Okay, that's an interesting concept.
Yeah, because those are not cheap procedures.
No. Yeah.
So you got some economics for owners do.
But that's really interesting what you say there, because as say you'd lean to MRI if it was like the soft tissue uptake, you'd lean to CT if it was bone. Interesting. Well, I'm sure that'll shake out with time. Yeah, and some horses, well, they'll be worth enough that they'll get everything, right?
That's true.
And again, that ability to co-locate everything, like you can put if you can put this together in MRI and like a bone imaging technique like CT, I mean, that's going to be pretty impressive stuff. You're going to find a lot of lesions you didn't think you had.
Yeah.
which is evidenced by that study that you've already found out more than you ever
Even
thought
I
was
can read
possible.
that.
Yeah, seriously. Bart, there you go. I mean, if Bart can see it, it must be obvious. Whoa.
If we could go from a big red spot to just putting a Band-Aid over the area.
Yeah. That's exactly
We'll work
right.
on that.
This big sort of thing saying "tis here."
Arrow.
"Tis here."
Yeah.
That's fascinating stuff. Well, Erica, this has been a fantastic talk. I mean, really exciting stuff that you're doing. And as I mentioned before, we're so glad that you're here because you're going to add so much to what we do.
Yeah, we're thrilled to have you here. It's great to have somebody with your credentials on board and your background. It's good. It's really good to have you here.
Yeah. Fantastic. And that was StallSide this week. We were talking to Dr. Erica Dobbs here at Rood and Riddle Equine Hospital about advanced imaging and the PET scan.
Hit the like button and follow us.
Well, they like you. They're a little bit divided on me.
No, that's not true.
Work in progress.
Star of the show.
Okay, see you next time.